morning, everybody. Thanks so much for coming at this very bright and early hour. I'm Maese Rau. I'm a pediatric oncologist at Seattle Children's, so it's 5 a.m. my time, so just thanks for being here and bear with me since it's a little early. I am here today with Luke Maese, who is a pediatric oncologist at Utah, and we'll introduce him a little bit more momentarily, but we're really excited for you all being here today and talking about one of our favorite topics, asparaginase. So, if you haven't already done so, please complete the pre-event survey. I think it's still available through your apps. And then look out for additional polling. This is intended to be interactive, so keep an eye out. We're going to be asking some questions, and we'll throw it out to the audience to give us their thoughts. And the more you do that, there is incentive because there is an additional prize. So the more you respond to the the more opportunities you have for this $50 gift certificate. So scan that there. I think you also have it on your table so you can participate. And then, for afterwards, materials will be available for additional learning for future use. So we're going to start off right out of the gate with a question. Which issues commonly limit your ability to maintain planned asparaginase exposure in pediatric AYA, acute lymphoblastic leukemia, and lymphoma? Select all that apply. This is not just a one-off. So distinguishing hypersensitivity from infusion reactions, assess logistics for alternative formulations, prior severe toxicity leading to discontinuation, family adherence or scheduling challenges, and comorbidities that delay delivery of asparaginase. So I'll give you a moment to do that. It's a pretty even split. I think the bottom line is there are lots of issues that might interfere with your ability to deliver asparaginase to your patients. So we're going to dive into some of these. Certainly can't address every possible issue that you might experience, but I think we're all in the same boat when it comes to these issues. Okay, so just to sort of for today, number one, we'll discuss how failure to complete planned courses of asparaginase during therapy might lead to suboptimal outcomes. Asparaginase toxicity, including hypersensitivity, is a major factor leading to suboptimal asparaginase exposure. We'll talk about the fact that if a hypersensitivity reaction occurs, you have to plan for sequential use of a different asparaginase formulation, and then we'll talk about the delivery of that sequential asparaginase formulation. That's me. I've already introduced myself, so we'll go right ahead. So I sort of like to start with a historical perspective. Asparaginase has obviously been a cornerstone of therapy of ALL for quite some time now, and this is just sort of a timeline highlighting its clinical development over the decades. And we have here starting in the 60s. Can you swap me on? Sorry. But I would take one step back before that, 1960s, and really, I wish I had another poll because I think an interesting bit of history is the very first asparaginase product did not come from a bacteria, but it actually came from the humble guinea pig. For reasons that are still completely unclear to me, in the 1950s, a group of researchers exposed lymphoblastic lymphoma cell lines to a variety of animals' serum, and they found that when they exposed these lymphoblastic lymphoma cell lines to the guinea pig serum, the cells died. And through some biochemical studies, they identified asparaginase that was produced by the guinea pig as being the agent in there that was resulting in the anti-lymphomatous activity. And they found that was because lymphoblastic leukemia lymphoma cells do not have an enzyme called asparagine synthase, so they can't make their own asparagine, and they must absorb it from the external environment. So if you deplete that with asparaginase, then the cells cannot form protein, and therefore they die. Fortunately, it was subsequently identified that bacteria also produce asparaginase, first identified in E. coli. That's probably most fortunate for the guinea pigs, so we have alternative sources of asparaginase for our patients. And that was first found to have anti-tumor activity in the 60s. Subsequently, this was introduced into clinical studies, mostly in pediatric ALL, leading ultimately to the approval of the first asparaginase product, a short-acting native E. coli asparaginase, in the late 1970s. There was then a little bit of a gap, but folks were working to optimize the delivery of this really important medication. And so pegylation of these native products was undertaken, and that addition of the polyethylene glycol moiety extended the half-life of the drug. So instead of giving multiple doses to result in depletion of asparagine for prolonged periods of time, a single dose lasted in the body and could result in prolonged asparagine depletions. That was a major advantage. That was ultimately approved just in the early 2000s, so not that terribly long ago, that we had FDA approval of a long-acting asparaginase product, which very quickly became the standard of care frontline agent. Patients sometimes, as we'll discuss, can react to that E. coli-derived asparaginase, and therefore it's important to have alternatives available to them that are not immunologically cross-reactive. Turns out another bacteria called Erwinia chrysanthemi also produces an asparaginase, and that protein is not immunologically cross-reactive with the one produced by E. coli, so you can safely deliver it to patients who have reacted to the E. coli version. And the first of those products was FDA approved in 2011. We've had some ongoing attempts at modification and optimization of the asparaginase products that we have available to our patients. And a change to the linker between the polyethylene glycol and the asparaginase moiety led to an even extended prolonged half-life with a drug that's now FDA approved called Asparlis, and that is what's mostly available to our patients here in the United States. In 2019, recognizing its importance in the role of ALL therapy, pegylated E. coli asparaginase was added to the World Health Organization list of essential medicines. We had manufacturing issues with the original native Erwinia asparaginase, and therefore work was conducted to create a product that was more readily manufactured, and that was a recombinant Erwinia product that we'll talk about some today that was FDA approved in 2021. And then its label was extended to a Monday, Wednesday, Friday dosing schedule in 2022. All right, so we all use asparaginase for our patients with ALL. How we use it varies a little bit. So just sort of touching on what I put into sort of two major ways in which you utilize asparaginase, and it depends on which protocols you're following. Dana-Farber has really been the pioneers driving the incorporation of asparaginase, and they really rely on it heavily for the treatment of their patients with ALL. In particular, during their consolidation portion of therapy, so that's the time between induction and maintenance, they have periods of time in which they aim for continuous depletion of asparagine, so up to 33 weeks for their high-risk patients. So you're getting continuous doses of a pegylated asparaginase product to result in complete asparagine depletion for the entirety of that time period. And this has been adopted by a number of other consortia as well. The Children's Oncology Group and a number of other consortia do it in a slightly different way. We have doses of asparaginase throughout our therapy, but it's what I would call intermittent dosing. So we aren't aiming for that continuous 30-something weeks of depletion of asparagine, but we're giving doses of asparaginase throughout therapy across different phases. So asparaginase is important for our patients, and we have a number of products available. Pegaspargase was the original pegylated E. coli asparaginase. That was the workhorse for many years, and it was FDA approved for all of our patients, and it was given no more frequently than every 14 days. Calaspargase, or Asparlis, has now replaced that for our patients who are 21 years of age or younger in the United States. It doesn't have approval in other jurisdictions yet, but probably rolling out elsewhere. And this is the longer acting. You can see the difference in half-life there. Pegaspargase given IV has a half-life of 5.3 days, and that's extended to 13.4 days for Asparlis, so quite a bit longer. There are two Erwinia-derived products. The original, the asparaginase Erwinia chrysanthemi, is the product that comes straight from the Erwinia bacteria. This is the one that had lots of manufacturing issues, and so we were struck with drug shortages for some time. That actually no longer has an FDA label, so you can't get it here in the United States, but still limited means available in some countries, but I believe that product is ultimately going away entirely. Fortunately, we have the recombinant version, so asparaginase Erwinia recombinant, or Rylase, is a product name, and that was recently FDA approved and is now available for our patients. So why does it matter? It matters because I don't know how many in the room lived through those times when we had these severe and prolonged shortages of Erwinia asparaginase. And so you would have a patient who reacted to their PEG asparaginase, and you had nothing to give them. And families would say, well, what does that mean for my child's possibility of cure? And we had no idea. Like, well, we hope that all these other medicines we give on your chemotherapy backbone will sort of make up for the fact that you're missing, this one medicine. Sumit Gupta and others from the Children's Oncology Group looked back retrospectively at our data and said, okay, what actually happened to those patients who missed asparaginase doses, mostly because of those drug shortages? And unfortunately found that amongst those who are on the high-risk backbone, so they're getting up to 7 doses of asparaginase in total, if you missed even a single dose throughout that course of therapy, your chance of relapse was 50% higher, so quite strikingly significant. NOFO has done similar work, looking back at their patients, and found that those who had to omit courses of therapy, which they here call truncation of asparaginase therapy, had significantly higher rates of relapse. And another study in mostly AYA patients found a very similar increased risk of relapse in patients who had to miss some of their asparaginase therapy. So I think we've reviewed some of the importance of asparaginase, so now I'm going to hand it over to Luke, who's going to talk a bit more about the journey of giving asparaginase to our patients.
All right, we'll see if I can get as good of applause as that one. Now, it's not as early for me as it is for Rachel, because I'm in Mountain Time Zone, but I had scotch last night and she had a beer, so that's my excuse. So thanks for joining so early, and happy to talk about this today with you all and anywhere outside of this format too, about asparaginase and other ALL and lymphoblastic lymphoma-related items. So how we thought about doing this, and many of you have been to these before, I think talking about a case helps people visualize this for themselves in terms of how do they frame this discussion that we're having on this topic and asparaginase in general. And so we're using this case. We'll kind of throw in some different changes here and there, and then talk about some of the aspects of the case, but then also talk around the asparaginase in general, not necessarily with this case in particular. But we have a 19-year-old AYA who has lymphoblastic lymphoma. You can see his BMI there, a little bit high, and is on a treatment with CALGB 10403. So again, a very similar treatment that we use in the Children's Oncology Group and in other groups as well. So 10 minutes into their first asparaginase infusion with cal-asparagase pegol, they develop some symptoms that include pruritus, flushing, some urticarial rash, and then some other generalized symptoms. So this is not something that I think if you have been doing this at all for even a short amount of time, have not seen before. This is pretty common, and it doesn't necessarily have to be with asparaginase, but these are situations that are very kind of tense for people in clinics and nurses and providers, pharmacists, us all. And so with these patients, I think we have some questions on the iPad already that have come in on this. I think these are very difficult questions to answer. But what do people think, Rachel? What do you think? Does this meet presentation? Does this meet criteria for hypersensitivity? What do you think about that? And then the second point in terms of an infusion reaction.
So I think, as you said, this is pretty common in the pediatric oncology clinic. I would favor infusion reaction for a few reasons. Number one, this is first exposure to an asparaginase product, which is less likely to have already formed antibodies that would be reacting to that. While the symptoms are largely overlapping with a patient who has true antibody-mediated hypersensitivity, I'm not seeing anything like angioedema, no respiratory symptoms, no clear hypotension, vital sign instability. So this is a patient for whom I might strongly consider rechallenging as a likely infusion reaction rather than antibody-mediated hypersensitivity.
Yeah. I mean, I think those are things that people would mention and think about in that particular scenario, and I completely agree. And then, so what if we did this, right? We could change this because this is a talk and not the real world. It's nice that you could do this. But 10 minutes into the second infusion, So now we have the second infusion, and then you have similar symptoms. And then your blood pressure, though, this is often common, especially in pediatrics, depending on the size of a cuff that's being used, what the blood pressure is. I digress. So if you have a blood pressure that is higher and then it all of a sudden is lower, and then these other things are going on. And so thinking about how these things may change your interpretation of whether or not this is antibody-mediated or is this an infusion reaction. Again, these are just additional characteristics of a situation, and again, you're taking everything into account when you're talking to your team and the family and the patient about what you think is going on. So we'll talk about some asparaginase-associated adverse events and toxicity in general, and we'll talk a little bit more then also about hypersensitivity itself. So you can think about adverse events or toxicity for any drug in terms of what's more common, what's more rare. I think it's hard, right, to go through all the side effects that drugs have, given how much we use these different chemotherapeutics in a multi-agent backbone. But I think of asparaginase toxicity as having these four core kind of categories, including immunogenicity, pancreatitis, thrombosis, and liver toxicity. I think these are the ones that most people focus on. Obviously, there's other things, as you see in the bar graph there to the right, that's detailing some incidents of these toxicities across different trials in the United States and in Europe. So I think we know that these things happen. It's what makes them more common? What are the risk factors? We'll talk a little bit about this. How do we try and avoid these things? And then, what do we do when you have a patient who has one of these toxicities? And again, we've gotten some questions about what to do, and I think again, there's some guidelines here, but a lot of it is, there's an art to what we're doing here. So when we think about asparaginase toxicities, this is in particular with our case, right? We have a 19-year-old, and so this is an older patient. It's an NCI high-risk patient, or it's an AYA patient, kind of depending on how you're thinking about it and where the patient's being treated, adult or pediatric center. We know that these things are different across certain risk factors, like I said, and we know that older age is one of these risk factors. This is an older data set now, but not super old, from our colleagues in the Baltic and Nordic areas, where they enroll patients on their protocols up to age 45, and you can see some of these differences in toxicities across these different age ranges, and how this can be affected. And I think, again, doesn't mean that it can't happen in certain ages or anything, but these are things that we know are a part of what we're doing. And so when we talk about the multiple risk factors, right, we can think about patient-related risk factors and treatment-related factors, where we see some increased or maybe even decreased amounts of toxicity with asparaginase and of course, other medications. So in terms of patient-related factors, again, we talked about older age. We talked about this patient's BMI, being on the higher end. And then there's some other things that you can think about in terms of a patient's history itself. And then we think about treatment-related factors, right? I mean, what is, how much of a drug you're using? What is the dose? Sometimes people think, more kind of higher doses, is this associated? And I think, again, there's differing, depending on what type of protocol you're using. As Rachel went through, there's different ways to deplete asparagine, and some of this data is different across how you're actually using the drug itself. And then what else are you giving a patient? I think it's always hard, and I think it's always good to keep in mind learning more about this as we think about the new agents that we're using and how we're getting the information we're getting. So we're collecting information in the Children's Oncology Group for certain things where we know that a patient has pancreatitis. Well, yeah, we know that's associated with asparaginase, and obviously, right, we blame it a lot on this compound, but there's other things going on with those patients, and when we're collecting this data, we don't necessarily get attribution, and I think it's really important to think about that when you're looking at these big data sets and how the data is collected itself. So when we think about the strongest predictors of some of these things, of severe hepatotoxicity, pancreatitis, and thrombosis, these are associated with patient-related factors, and then of course, the multi-agent, kind of multi-dose therapies. The higher, more you get, right, in the NCI standard risk, you're not getting as many doses of asparaginase in the COG backbone, but in the high-risk patients you are. And so again, you're going to have some different related toxicities because of the choices that you're making with therapy. So this is an adaptation. I mean, this is a figure that comes from a paper that is older now, but I still think, again, these things haven't necessarily changed. We talked about the differences between infusion reactions and hypersensitivity and how you may find one more common or more likely, I should say, than the other. I think you can see what I get from this figure is there's so much overlap, and we like to try and give people definitive answers, but those definitive answers are very difficult, particularly when we talk about immunogenicity. And it's also very hard to make those decisions in the moment too. And so I think one of the things that I kind of emphasize is being patient. Obviously, we want to make sure the patient's safe, but before we're making these drastic decisions about what to do with therapy, think about the event, talk about the event with the team, and especially if you weren't there and you're talking to someone who was and it's your patient, these are things that we have to be very careful about. So I think we're always, again, trying to find ways to put somebody into a bucket. I think we like buckets in our field, and we're trying to make these buckets smaller so we can be more kind of personalized, more more specific to that particular patient situation. And when we think about infusion reaction versus hypersensitivity, right, you want to try and find these buckets. And like the last slide showed, there's different things that overlap. Just some highlights in terms of an infusion reaction. I think this question of ammonia comes up quite frequently, and I talk a lot about this in jest because there's lots of unknowns about what to do with an elevated ammonia and how many people are checking their ammonia levels and when and what that means. I usually just tell people, in my opinion, again, ammonia should go up when you give this drug. If it goes up, that's what it's supposed to be doing. And how high does it get, and does the patient have symptoms? I think these things are very challenging, and the more you check certain things, again, data is data, and I love big data. I'm not a data enemy, but I think it is hard when you have all of these values and you're not sure what to do. And so obviously, elevated serum ammonia can cause symptoms, and you could think about slower infusion or rechallenging. I don't. It's not just that, right? It's not just these things. It's all these things kind of together. In terms of a true hypersensitivity reaction, these things. I think Rachel said it last night. If you have angioedema, this is something that has been shown throughout many different publications, and this is something that obviously is very a concerning symptom. But there's other things that go along with this as well, and this is where you think about switching to a different formulation of drug. Okay, enough of my talking. Now it's time for more engagement. What do we think here? We're going to reconsider this case of this AYA patient who develops these symptoms, has hypotension during the second infusion. What is your interpretation of what's going on? Alrighty. Hypersensitivity, assay testing, certainly. We're not going to talk a ton about TDM today. We'll talk a little bit about it. But yes, unclear. I would re-challenge before deciding. Okay, no patients. I guess we're all patients. No people. Pick that one. Okay, great. Right. Okay, so again, just talking about this case, the timing of the toxicity, the presence of urticaria, these respiratory symptoms, and hypotension. This is consistent with a grade 2-3 hypersensitivity. I think most people in this room would probably agree with this. Obviously, this grading is tough, and again, we're not talking a lot about that. Much of it that is that's a little bit of a black box too. But certainly something that I would say is consistent with a hypersensitivity reaction. And so, Rachel, what do you think here about what we're going to do for this patient? We talked about those choices on the last question. What is our immediate management plan? What would you do in Seattle?
Yeah, I think this is a patient for whom we would switch to an alternative asparaginase product, which is the recombinant Erwinia asparaginase, which is all that is available to our patients who have a true antibody-mediated reaction to an E. coli-derived product. Just the data that we reviewed from multiple consortia across decades of time have revealed that if you don't complete all of your asparaginase courses, it's associated with an inferior outcome. So we do our very best to complete those asparaginase planned doses to the degree that it's safe for the patient. And since we have a viable alternative option, while it is more burdensome in terms of its delivery, we still recommend that for our patients.
Yeah, absolutely. I think we would do the same thing, right, guys? Yeah. I got some good fellows here. Woke up early. So I think I totally agree with that. And when you think about, again, modifying this case, what if this was a 5-year-old? I think 5-year-olds are different, right, than 19-year-olds in many different ways. I don't, for me, I don't know if that would change much of what we're talking about in terms of how we're interpreting what would happen in this scenario if you just changed the age. I do think, again, right, we talked about this last night as well, right now in the U.S., like our approval for recombinant Erwinia is for IM injections. Obviously, that's a different poses different challenges depending on the age of the patient. In a 5 versus 19-year-old, I think that is something that we would, certainly address with the families, regardless of their age. But again, would pose different challenges, but it wouldn't change what we would necessarily say or do. You agree with that, Rachel? Yeah. So, okay, what are our options then? We talked about these things in terms of how this is why it's important. Thinking about infusion reactions versus hypersensitivity. What are the certain different options you can choose? I think. This is why that decision making is very important, and certainly infusion reactions, whether it's asparaginase or a different drug, you can always try and do that again. If it's a hypersensitivity, a true antibody-mediated reaction, switching formulations was our kind of constant and things that we did for a long time. When we had the shortage, as Rachel talked about, people were trying to find other ways to do it, and more people tried desensitization, and that is something where there's some literature out there in single case, maybe multiple institution case series. But again, there's not a ton of data on that. We're trying to collect some of this now, but again, that is something that some people are doing, not as much anymore, given that we have Erwinia-based product now that's readily available. And of course, we do have a question on the iPad. What if they have problems with both? I think it's very hard to address, and oftentimes people do have to have their therapy discontinued. And again, we can have those individual discussions depending on the patient themselves. So what treatment plan will you now pursue to ensure exposure after confirmed hypersensitivity to pegylated product in the pediatric NAYA setting? So what do you think? This is 1, 2, 3, or 4? All right, okay. So most people would switch, some would do desensitization, some would maybe re-challenge. Okay, so, but again, the vast majority would switch, and that's kind of what we talked about. I think that is the most common kind of scenario that people would pursue in this situation in this day and age. Obviously, it was different in the late 20-teens. So when we talk about recombinant Erwinia, dosing itself, again, this case, you're deciding to switch. So what is the recommended dosing protocol? How do you involve patients and families, caregivers in these dosing decisions? So we'll go to the next slide and we'll talk a little bit about this, and maybe we can kind of talk around those questions as we go through these slides. So this is data from the trial that was conducted by the Children's Oncology Group in partnership with Jazz and looking at a recombinant Erwinia. And so we looked at these different doses, as you see in the bar graph here. The 4 separate kind of sections. You have our first cohort looked at 25 milligrams per meter squared. Then we had another one that was 37.5, and another one that was 25, 25, 50. And these were, again, all on a Monday, Wednesday, Friday. Those first 3 are intramuscular. The last one is IV. And this is the activity maintained via these dosing schedules in terms of serum asparaginase activity levels, and this was the proportion of patients who were above this 0.1 threshold that we set as kind of our benchmark. In the orange, you have the secondary endpoint, which was 48 hours above 0.1, and then our primary endpoint was 72 hours above 0.1. And you see that the 25 milligrams in the IM wasn't reaching that point at 72 hours, but the other two cohorts with IM were. In the IV cohort, again, we do get questions about this a good amount. This isn't recombinant Erwinia focused talks. We're not going to go into a lot of the details of the trial. Happy to talk about this anytime with anyone who's interested. But we weren't reaching this threshold again with the 50 milligram dosing at 72 hours with IV either. But we were with at the 48 hours. So we know that with this dosing you can achieve these appropriate levels, and if you're looking at some of the adverse related events on the trial, I think there's lots of data on every trial that has looked at asparaginase and how again it's grouped and how again we tried to do this again within the context of a multi-agent backbone. Always keep that in mind. And these were the readouts from the treatment related adverse events. And then we had these ones of special interest, which we talked about in the beginning of the talk. You're obviously going to have treatment-related adverse events with any product in our tool bag, and so we were seeing these obviously. And then if you look though about these ones of adverse events of special interest, you can compare across the different dosing, different cohorts, find some differences. It wasn't. This was, the trial wasn't itself designed to find differences in toxicities across these cohorts, but this is the data that we're reporting, and you're having some of this, increased hepatic kind of, I call it angriness, but again, this is these increased transaminases, and then we did see pancreatitis, we did see some allergic reaction and thrombosis. All of these really side effects were consistent with what we typically see with asparaginase products themselves. And so what the question really for this patient was getting at is this, and I think the way we went about the trial was to try and give flexibility to people, clinicians, patients, families on some of the dosing that we were using. And so we have these two separate dosing regimens. You have a 25-50 milligrams per meter squared dosing regimen, Monday, Wednesday, Friday, and then this is 6 doses, and then 25 milligrams per meter squared IM every other day. And I think, and this is for 7 doses, and this is only intramuscular dosing because this is what's approved in North America. And I think what we talk more about, if you get into the weeds of some of this, is in some of the smaller print, if you guys can see, I'm sure in the back, but talks about how many hours after a certain dose the Friday, Monday, or Wednesday dose. Now, this is something that we kind of went back and forth as we were getting our approval for giving this medication. And I think for us, this is very important. A lot of this is based on pharmacokinetic data. I think when you talk about what's reality is what we talk about in terms of how do you schedule your patients? Can you make these things, make this schedule work? Obviously, the PK data is more appropriate when you're doing it this way, and Dr. Pui's group showed this recently in a publication where they did this in the real world setting at St. Jude, and we're able to see that the PK that we showed in the trial, this dosing in terms of hours is appropriate. But again, is that feasible? I think for your clinic is the most important thing. So what do we then, so we're going to reconsider our strategy. When would you ideally schedule Friday dosing of a recombinant Erwinia after a successful administration of Monday and Wednesday doses? So would you do Friday morning, Friday afternoon, Friday when feasible? I'm not sure because I went through that slide too fast. Friday afternoon, okay. Friday when feasible. We have a little bit of smattering there, and I think, again, this will differ depending on your resources, depending on what you guys can do at your individual clinics. I think, again, it's just important to know, just like it is with the hypersensitivity versus infusion reactions, have the data and then decide what you want to do with it. So it's great. Okay. Now we get into something that has come up more and more as we're using more therapeutic drug monitoring. And I think this checking levels is something we always now are addressing, and I think this is very important when we think about what to do in certain patient populations. And many of us are checking levels. There's been lots of surveys and stuff, and many of us are doing this now because it's more readily available than it was before. So I'll hand it back over to Rach, and she'll kind of go through some of this therapeutic drug monitoring kind of questions.
All right, Jacqueline.
Oh,
It's a good fellow right there.
good fellows.
All right, so we've got our patient who completed their dose of asparaginase. You have appropriately sent serum asparaginase activity levels 7 days after the infusion was complete, and this is the level you get back. This means that the patient has what we call silent inactivation. So silent inactivation means that you have the antibodies that in most patients will cause the symptoms of an allergic reaction, but these patients have those antibodies but don't have an allergic reaction. However, those antibodies still do something bad. They bind to the asparaginase in the body and they eliminate it very quickly, so the drug is no longer effective whatsoever, and that's why you do not have therapeutic levels of your serum asparaginase activity. So where did that number come from? What is the asparaginase activity? So you could measure asparagine in the body. That's what we're aiming for. We want to deplete asparagine, but that is really hard to do. You have to have a special tube. You have to put it on ice immediately. And so those levels have been very challenging to measure in a clinical setting. We have measured them in the context of clinical studies, clinical trials, lab-based experiments in non-human primates, for instance, to really establish what is a surrogate assay that could tell us a level of activity at which we would expect to have complete asparagine depletion. And those are the commercial assays that are available in a number of different companies that we're hopefully all sending on our patients to monitor for silent inactivation. So this is just a graph from a clinical study that measured serum asparaginase activity versus asparagine. So what you want is to have complete asparagine depletion. If I have a little pointer here. So this is your asparagine. It starts at a pretty high level in the body. You give a dose of an asparaginase product and you expect that to drop precipitously. That is how asparaginase works. And then you can monitor the activity levels of asparaginase over time by the surrogate assay, and you see that as the asparaginase activity falls, at some point you hit a threshold where your asparagine rebounds and you start to have asparagine back in the body. And that threshold, it depends on what study you read, but overall 0.1 international units per mil has been established as the threshold that is most commonly associated with complete asparagine depletion. Anything below that, you might have a patient who's having asparagine detectable in their system, and therefore you've crossed that therapeutic threshold. So that's by and large the value that we would consider the therapeutic one. And if you're below that value at early time points, so here you can see, this patient still had complete asparagine depletion out to like 20 days. So if you're at day 7 and you're already having very low levels of activity, then you probably have asparagine depletion. And that means you don't have effective asparaginase in your system. You've eliminated it from your body. So that's why we would say that's silent inactivation. So in the Children's Oncology Group protocols, based on sort of data collected from a number of studies saying what your asparaginase activity level should be after getting a dose of long-acting E. coli asparaginase, we have this guidance. If you have a patient and you've checked it at a week, like our patient here, and that value is less than 0.3 international units, we would say that patient likely has neutralizing antibodies because that's a lower level than you would expect at 7 days after a dose of a long-acting asparaginase. But it obviously depends on when you have checked the level. So if you check it at 14 days, the value's lower. So if it's less than 0.1 at 14 days, that's also consistent with silent inactivation. Okay, so Luke touched on this, and we've talked mostly about hypersensitivity. We certainly haven't solved hypersensitivity because we all know it's still hard in the clinic to identify infusion reactions versus a hypersensitivity reaction. But there are other things that we can run into challenges with. Pancreatitis is particularly problematic, especially for our older patients. That is a risk factor. The rates overall are 5 to 10%, but that goes up as you age. There have been some genetic factors predisposing to pancreatitis, which I think is really interesting research, and we don't have time to sort of get into. But hopefully this will be sort of on the pharmacogenomic panel as we all move forward, so perhaps we can do sort of closer monitoring for those patients at risk. What do you do after a pancreatitis is challenging. Those episodes can be quite severe and even life-threatening, of course. But the data support that for most patients who have had an episode of pancreatitis, if you re-challenge with asparaginase again, about 50% of them will not have a recurrence of their pancreatitis. So that really depends on if you're a glass half full or half empty kind of person, right? I think if you've had, what our guidance generally has been, if you have a mild grade 3, so the symptoms lasted less than 3 days, the patient didn't have a pseudocyst or insulin dependence or anything like that. And that's a patient, especially if they're a high-risk patient for whom we know asparaginase is of critical importance in achieving the highest likelihood of cure. That's a patient that I would probably re-challenge. If it's a 5-year-old who had just one more dose of asparaginase, I might say maybe it's not worth that 50-50 risk for that particular patient, but I think it should be based both on your expected risk of the recurrence of pancreatitis and the expected benefit. So how important do you think asparaginase is to their opportunity for cure? Thrombosis, Luke talked about. This is one where you get them on a good anticoagulant and you push through. This is not often a cause for omission of asparaginase. And then hepatotoxicity is really most problematic during induction. You have a patient who's obese, so they probably have underlying fatty liver. They come in with a liver infiltrated with leukemia cells. They're on steroids as well. That's probably the perfect storm that sets them up for these what can be pretty severe episodes of hepatotoxicity. They come into clinic on day 22 of induction, just yellow, with really high conjugated bilirubin. So those patients can get quite sick, and that's quite concerning. Fortunately, we see with subsequent doses of asparaginase in later cycles that you're less likely to have that severe episode of hepatotoxicity. So these are patients also for whom it's appropriate to re-challenge after they've recovered from their hepatotoxic event. All right, so this is just, I think, wrapping up. We've talked a lot about the problems that you can run into that might hinder your ability to give your patients asparaginase products, a product that we know is very important for their likelihood of cure. Hypersensitivity we talked about. Fortunately, we have some strategies to overcome hypersensitivity reactions by replacing with a different formulation. Same thing for silent inactivation. It's the same process. You have antibodies that are both causing symptoms they're both eliminating the drug and or causing symptoms. And for those patients, we have a product available to switch them to. So I think those are all the main takeaways, but we have a lot of really good questions that I think it's probably time to get to. So let's start there. But thank you all for your time and attention and for showing up so early on this conference day.
Thank you. And then at the end, I think we have so many questions here, and we have a little bit extra time because there's always so much to talk about with asparaginase. We always run over. So there's some great questions here, Rach. I want to address maybe a group of them in terms of demographic associated toxicities. And we talked a little bit about this in the beginning and at the end. Again, it's hard to go over it like in a ton of detail. So in these group of questions, there's a question about obesity and dose capping. Now, again, certain people have different opinions on dose capping. I do think that there needs to be more bigger data sets in terms of what dose capping, what the implications of that are, but we do a lot of that, I think, with pegylated product. In terms of the Erwinia-based product, we didn't dose cap on the trial. It's not something that's really been done, to my knowledge, to any large extent, even before the recombinant Erwinia, even with the OG Erwinia. So I don't ever recommend dose capping with this drug. Again, when you're using a shorter acting product, if you start dose capping, I did actually get a question from Australia, our colleagues down under, and this group was giving 10 milligrams per meter squared of recombinant Erwinia, and they were achieving a peak, but it was just not lasting as long. So I do think if you start dose capping, again, this is obviously less than what we even studied, so it's just not something that we do. Rachel, I don't think you do either.
No, yeah. My gut is that a lot of those toxicities that we experience with the long-acting is probably due to a really high peak, and you never get the same height of those peaks with your short-acting products. So we haven't recommended it, and just for the reasons you outlined, you probably then have far less therapeutic window with which to work. So I also wouldn't recommend that.
And then there's a great question here from Dr. Sharp who asks about race and ethnicity and difference in toxicity. So I'll send this article to Deanna for the meeting, but we recently published an article. Itan Orgel led a big kind of data set in terms of the COG on 0232 and 0434 of data in induction only with some of these demographic associations with toxicity and all the 4 core toxicities we talked about. And there is some association with hepatotoxicity. Some of the other ones, though, there really isn't. So again, this is a large data set. Again, it's only across induction, and I think that's the other thing. Like, a lot of the stuff we're doing here is only an induction consolidation, and so you're not getting the complete picture. Anything to add on that?
I think what was clear from that, and then a number of institutional studies, is obesity is certainly the highest risk factor for hepatotoxicity. I think there was some association with pancreatitis, less association with, for instance, Hispanic ethnicity, which is something that I think was a big question in the field. So.
Right. Yeah. And then on that, there's a question about severe hypertriglyceridemia with asparaginase. And I think this is something that comes up not infrequently now, especially with obesity, and even non-obese patients are having this, and we're picking this up more frequently. I would say we don't see it as much with non-pegylated product, but you could still see it. I don't, I think our approach to that is to really just try and bring the numbers down and do what you can. It's not an indication to discontinue therapy. It's in the COG protocols, and most people would not do that. I think it does make people a little bit nervous. Certainly with pegylated product, maybe less so with non-pegylated product, but what's your take on the hypertriglyceridemia?
It can be really problematic, and with Calpeg's really long half-life, we've seen really severe hypertriglyceridemia for a really long time. So, those are really challenging situations. We get them on fenofibrate, and, we try fish oil and other things like that, and it might make a little bit of a difference, but I think that's still a real challenge. And while it's not an indication, because it really correlates the length of the hypertriglyceridemia with the length of time you have asparaginase activity, I have, in severe cases, switched a patient to Rylaze just so I know how long the hypertriglyceridemia is going to last. That is not an FDA-approved indication, of course, and that was a sort of patient-specific situation, but it was a kid who really had triglycerides so much that you couldn't even accurately measure your blood counts for some period of time, and it just really lasted for the entire duration of asparaginase. So it's tricky and it's challenging, and we all are seeing patients in our clinic with it.
Yeah, I think it's hard.
We have a great answer. Yeah.
I mean, we rely a lot on our colleagues, in cardiology and endocrine and some of these things to work through these things. But again, some of the stuff we've had in Utah is that they see hypertriglyceridemia for other reasons, and then they're trying to extrapolate that to this. Yeah, I think it's a little bit challenging. Let's talk a little bit about hypersensitivity now. There's a bunch of hypersensitivity questions. I think I don't want to spend too much time on this, but I think we should give it some airtime in terms of hypersensitivity rates, infusion reactions, hypersensitivity, whatever, with the different products. I think, there was some consternation behind the switch from our previous pegylated product to the now pegylated product we're using in North America, cal-asparagase, Pegol, and I think there were some concerns about increased toxicity with this drug and increased reactions, hypersensitivity. I think and there's been anecdotal reports. I mean, my center put out a report on this, and I think other centers have as well. I guess what I would say is we need to get more data. That's my opinion. Rachel knows how I feel about this. I mean, I think we are making assumptions based on small amounts of data and anecdotal experience in different times. I think immunogenicity is really hard to make snap judgments about, because obviously it's not just the drug. There's other things going on in our environment, and so I would say that this does ebb and flow, and it'll be nice to see larger data sets. What do you think about this question? And
Yeah, I mean, I think with any new product and we're creatures of habit, and when you make us change, then we get a little nervous, I would say. And so, I think there's probably was a true signal of some changes in the toxicity profile with the new long-acting asparaginase product. But agree, we need large data sets to really nail down what the frequencies of those toxicities are. And with that, I see they're putting up the queue for us to wrap things up. We have lots of questions we weren't able to address, but Luke and I can hang around afterwards and love to chat with folks. And then there's some material available online afterwards. Thank you all for coming and for your great engagement, and enjoy the rest of the meeting. Thank you.